injustice related to knowledge. It involves treatment of individuals in their capacity as well. This concept was introduced by a philosopher called Margareta, identified two types of epistemic injustice. The first one is when a speaker words giving less credibility. For example, if someone is believed or is ignored because of the race, gender, and other aspects of their identity. The other type of epistemic injustice happens when there is a gap in quality interpretive resources, make it difficult for someone to make sense of their experience. For instance, before the term sexual harassment, for example, was widely recognized, many women struggled to articulate their experience of this. On this picture, you see some of the women from the work. When you see many people, when they see this picture, will think of them as vulnerable and lack knowledge. And these women have experienced a lot of epistemic justice related to social care and institutions in the society. And in many ways, they have been seen as targets to be fixed, not as a capacity in the society. In 2016, Malmö University took the initiative on an innovation agenda called Equal Health in the discussion about a new life science strategy in the region of Scania. This was done in collaboration with actors and the universities in Scania, and we concluded, all stakeholders there, that we needed to create more health promotion platforms in the society. Together with all these stakeholders, both business or public sector, academic, and a lot of non-governmental organizations, we got funded from Innovation Agency and Innova to build this program, Equal Health. The program scope was built on organization together with the local populations from what we can call a perspective. And in this, it was a clear focus on the citizen, both in the research and in the local community with the organizations. This was our goal. We want to reduce health inequalities because more equal health leads to economic growth. When citizens as individuals in what we call social trade, together with researchers, students, societal actors, civil society, and others, within a framework that itself is helping, benefits arise for both society and also business. In a new governance collaboration between ideas emerge without fence thinking between different organizations. And the problem in existing system can be identified for development share. We started this program in a day with a lot of migrants, many families with poverty. There's a lot of child poverty and the increased problems with mental health or chronic diseases. The program is built upon CBPR, the base participant research, where you do all the research together with stakeholders and the citizen. In this model, we now look at knowledge from a more democratic perspective. We also experience relational, reflective knowledge. Stakeholders, citizens are part of the process. All the research only focuses on the needs of the people. And they are all represented in the research program, building up this organization and taking part in it all the time in the neighborhoods, social meeting places. And this community of practice becomes a social infrastructure for citizens from other places also can attend that are these kind of activities. Everything is implemented in research. I call this knowledge mobilization. And it's also a democratic epistemological sense. Often we see research as scientific knowledge using quantitative methods or qualitative methods, like interviews and observations and which are called optional entity human experiences, such as knowing someone or understanding them. And this knowledge is critical for building relationships and quality of life. It connects people to mutual understanding. Another kind of knowledge is reflective knowledge. It's come from critical reflexivity, increasing awareness of societal dynamics. This knowledge is essential for social change and addressing health determinants. So participatory research and community-based participatory research aim to foster ethical sensitivity and social justice in local practices. And this kind of research use representative content, but what differs is that it also goes into the relational and reflective in its epistemological approach. Because identity injustice also occur in research, but there's a lack of this relational reflective knowledge, leading to misinterpretations and feelings of shame and guilt for them. When it comes to promotion or prevention, which is the area. You know, promotion, it is about health based on a positive phenomenon that what wants to strengthen. Prevention is to prevent for diseases, psychological and social problems. To create a more holistic health perspective, we have to work with health promotion in a way with the community that also interact with prevention. Prevention also in social care, not only that. Because today it's a gap. And a different kind of organization working is worse. So we have to fill that gap. And one way to do that is with, I call, groups. Groups community organization with different organizations from social care, sport associations, system, and facilitating activities and working with us as researchers in a community. And these people are very important since they're mobilizing different kind of knowledge in the community and between organizations. And now I'm going to show you a video. So you those later. So let's see if this works.
När jag pratar om försäljning så betyder att det här är så mycket större, så mycket mer komplext än vad en forskningsprojekt. Så jag vill hellre kalla det program som också innehåller forskning och forskning. Och det är ju väldigt mycket aktiviteter baserade samverkan. Som plats och inte minst och i detta så försöker vi också implementera en forskningsplattform för och utvärdera.
Det är ju fruktansvärt alltså att vi ska ett samhälle där människor där det finns ojämlikheter i hälsa. Det är största orättvisor som finns. Och det måste vi naturligtvis försöka göra någonting åt. Och det fordrar annat än det man har idag.
Det finns några komponenter som jag ser som centrala. En av dem är just det här att medborgaren inte bara engagerar de faktiskt driver dem som alla andra.
Så när det gäller det här med medborgare, det har vi haft så sjukvården patientföreningar eller representanter från brukare säger att man ska ha med en grupp processerna. Men det är felaktigt på det sättet som vi gör i det här.
Jag menar, staten börjar utifrån det är inte någon annan som bor i området som egentligen bäst kan identifiera vad det är som saknas eller vad det är som funkar. Angreppssättet att faktiskt jobba utifrån de som bor här och ringa in vad det är som behöver göras och spänna och sen att det sker i samverkan. Sen, andas in. Andas ut. Evelina.
Det centrala är att manifesteras i hälsoföräldrar som är de personer som för befolkningen och utan dem hade projekten hade forskning för att skulle säga.
Istället om en allvarlig faktiskt.
Jag fick med självförtroende när jag fick jobb. Från min sida, jag tänker jag fick mycket stöd från olika aktörer. Jag bygger mig själv. Jag känner mig stark nu. Jag känner mig riktigt personlig. Jag känner mig mycket. alltså, jag måste säga, min hälsa och kostverkstad så bidragit till att öka tillit och trygghet i området Lindvägen. Alltså folk började ha tillit till varandra och började se alltså, skillnaden i deras språk till exempel. Började alltså gå ner i vikten och detta, alltså första som lyckades många familjer att komma till min verkstad. Alltså jag måste säga att de började se skillnaden i deras språk.
Det kanske skapades så blev det ett maktskifte. De som sitter lite högre positioner tappade väldigt mycket makt utifrån att det var vi hälsofrämjare som var tvungna att ta makten och ge dem till folk. Det var väldigt började slog sig tillbaka.
Ska jag vara ärlig. Och sen att tillbaka sig till det sida. Det som har varit viktigt för mig är också att det är lite olika vetenskapliga discipliner. Jag är inte ensam där i min forskning från biomedicin till det sociala.
Frågan att utvärdera två städerna som finns i dessa projekt. Och en som är fysisk aktivitet och den andra är motion. Då har vi kommit fram till intressant resultater. Precis att intervention var en förändring i livskvalitet. Men efter 6 månader det var ingen förändring i sen får bli uppskattad livskvalitet. De tänkte att de inte mår bra. Även om de fysiska verkligheten mår bra. Även om det var en förändring i fysisk hälsa. Och när vi gjorde intervjuer vi kom att veta att de hade ingen kontakt med intervention. De hade inte haft denna grupp som de hade träffat och umgåsat och den sociala biten. Viktigaste frågan.
Vi kan visa frågor som skaffar sig vissa bättre. Och
när vi hittar hållbara modeller så också hälsa sig ha effekt på hälsan. Så det är kort som så är det ett fantastiskt arbete på att fortsätta.
Here you can see the organization that we have for this program. The stakeholders are supporting the not the opposite. And citizens are involved. These women as local health providers, facilitating and mobilizing the activities. It's a local hub in the it's a strategic group that also look at the transfer from the knowledge transfer from the local to also see if they can create some policies. The local health providers is not only also sitting in the hub, they are sitting in the strategic group. And that's very important because organization strategic talking about the vice chancellor at the university, some high level, and they have to meet these people. Something's happening, so it's very important. From the resource that we get from the community, different labs are located in this neighborhood based on the needs of the population. And then the women create pharmacies, social care institutions. How do you start this process? work with a specific model in CBPR. And I can say building trust between each other is the more thing. And it takes time. It involves conflicts. Of course. It's not necessarily consensus. It's about taking advantage of each other's differences and moving forward. Moving forward. And it requires a specific ethical stand. On every Monday, there are meetings held between all the organizations working in this area. Talking about what is the problem, what are we going to do, so they can address alarming issues that, for example, exist. It could be distrust of social services, chronic diseases reduced from healthcare, working is very effective in cases such as the pandemic. How we have a problem. So trust building is very essential. When we start to solve problems or reduce the problem, we are inviting the whole community in large discussion forum, where health promoters facilitate. It could be over. We also distribute flyers and make personal visits. Health promoters go to the libraries, go to the youth center, and so on. And the local hub is helping in this work. The entire process is research integrated, researching using CBPR methodology. So it's an iterative process. So the result from this kind of bigger workshops, then it goes into the hub, the health promoters, and then 4 different activities which we call lab together. You can see some of the lab that was in the first action circle. Here, so social with the use, it was physical activity and so on. These activities changes because they are connected to the people's needs. So in these labs, we work with what we call CBPR health intervention as researcher. When we work together with the citizen, trying to see how can we solve problems. So there are 2 processes going on. What happens in the area is important. The primary care with diabetes 2. There's a lot of young people coming to the primary care and having diabetes 2. Anders was talking about that we had started a collaboration here in also about this because we have seen the problem in certain areas also. So there were 2 processes. Slogan here has worked with this. So to solve that, we started then, as you can see at this picture, education intervention because the women wanted to help and to more have more knowledge about how to prevent the diabetes in the families because there were a lot of problems in the families. So we were working with them on the primary care, educated, coaching families that are coaching the city now how to prevent diabetes. Dialogues and critical reflection, as you see on these pictures, is very important. Research and community members are involved in this CBPR intervention. And they also have critical reflection. Another important issue was a problem with social care. We have threats from outside saying to families, they get message on social media and so on, that social care to their children. So they were afraid to seek help. In this picture, you can see the lady notice in the front, Buddha, and women from the area, the police, and social workers trying to solve this problem together. So there is a lot of activities going on all the time, from social issues to more medical problems. But the thing is that it is the citizens that are building the There's many women that are activities today. So in the community is also outside this neighborhood. Here's a picture from the COVID. We worked a lot helping people in the area during the COVID. And they get help from our labs and help from the day health promoters. And if you talk to these women, that is super important during the COVID. As researcher, we also measure what happens during the pandemic and with the groups that we have, getting worse. We're helping to them. Another thing is that physical activity is not equal to gym, because that some people can't afford. So we work with other things, and they have chosen to yoga because they feel that they have stress and so on. But you can see they are themselves activities. So the role of the academic is also to support, you can say, social, civil society and citizens in a democratic approach based on human rights to reduce this, what I call epistemological injustice. One important thing here is that PhD students work all the time. So there is an interaction between the education system, the community, where they transfer knowledge back to the education system. For example, to the nurses program and to the social workers program. These women have situated that they can contribute with. And when they learn that this knowledge is very important also and could benefit for the society, their empowerment starts to grow. And they become very proud of what they do. And this is 3 PhD programs that you can see on the picture. Rati is sitting over there. She's already finished. She's PhD, so she continued to work with Shiva. I think you can hear it. It's another one working with the women. So it's very important to have that support to the community and work together on equal terms in this program. This we can see the program because we have to do that. You know, the health will increase. We can see that it's increasing health in the quality of life. We can also see that the stress decreases. We have also done some biomedical measurements. You can see that on the video. It's not our suggestion, because some of this and they have a lot of measurements more than health that they can put. But it doesn't work the same way here. So they want to have health controls, they say. So students. So we are also measuring the health. And it's a lot of empowerment processes going on. So we know the program works. And they work very good because of that social coalition that they have. The small things happening every day, helping each other in the community, working together, the whole society working together, both care, social care, so on, no barriers. So there are another life opportunities for many in the community. Yes, this program has been spread. I think Michael already mentioned that. So the city of Malmö has taken a decision to implement it in their political program. And one important thing is, you can see on the right here, is that the whole society need to work together. And the non-governmental organization, as well as the citizen, has to be as important as the other one. In innovation, for example, we always talk about something called business and academia work with the society. It's not enough. We want this model. Then we can change something in the society. Because a reflexive society emphasizes individuals and politics' active participation, not passive perception. It enables people to reflect on power dynamics affect their daily life, to strengthen democratic process in research and participatory approach. Research is used, and it's often influenced by forum frames educational fields. In CBPR, the researcher is supporting these evidence-supported processes, not just watching. Ensuring that the participants are not influenced by others. So critical reflexivity, social workers, nurses, planners, country workers, whatsoever, to question their own beliefs and knowledge within power imbalance. A critical reflexive team professional understand that being expert in power project means partnering to promote other goals. And this also involves an epistemological statement at the university organization ready to change their own structure. To avoid epistemological injustice and achieve a society, we must work together in cooperation processes. It's through building capacity in local societies that we can build new solidarity. In a shared capacity building within a social infrastructure aiming to reduce health disparities. And this also involves a change in an epistemological position that universities take in their research and education. How do we describe knowledge? And what is prioritized and promoted in our own system? Well, as Michael also said, we have now started a new platform where we should work with this kind of methods in a more democratic way with citizens and organizations out in the society. I will now finish my talk with a quote. I hope at least the following will endure: my trust in the people, my faith in men, and in the creation of a world which it will be easier to learn. Thank you.
Thank you very much, Margareta. That was absolutely perfect, I think, for the theme of this conference. I mean, also coming as a political scientist, where you're talking about the issue of trust, you are talking about relations, you're also talking about roles, and also the different stakeholders you had up there in the previous slide. I think sort of is really gets to what we're talking about here in terms of which actors need to be part of healthcare, and also how do we make that possible. Just whilst everyone is thinking about questions, and we have about 20 minutes, I think, for questions. Just whilst you think of a question, I just want to start off. I just want to take advantage of my role here. What I want to ask you is, because of course, where you're talking about trust, when you're also talking about the roles, and of course, a big part of the roles is that you can identify who needs to be part of this. So you're talking about communities. The experience you have from implementation, both where you're directly involved, but you see others sort of implementing these ideas in practice. How do we deal with the problem of scale? Because, you know, the case you're talking about with Lindhagen, this is a particular region within the city we're in now, of course. What happens when we move to, or is it possible to move to the national level? What happens with all the knowledge asymmetries, the power asymmetries? How do you overcome that? What are the structural solutions?
Well, the program is implemented in a local area, so it's local in its approach. But the method that we use are similar. So you can use it in another neighborhood or city or whatever, you use the same methods. I don't know if that's a good answer. And then when you compare those, if you have them in different cities, for example, you have to do it in another way that you usually do. Comparing the results from the baseline, so to say, in the local. So that's why I'm talking. We have no methods in our traditional science that we can do this with that. So we're trying to see how we can scale it up.
Thank you. No, that was an excellent answer. I mean, also just to highlight, I mean, not to push you further on this, but just to highlight the words you used earlier. I mean, you talked about listening, just now you talked about being adaptive, and also like the point that you also kind of, you know, you frame this kind of humility where you talk about that we try rather than just sort of imposing a certain model. And I think that's really came out in your talk as well. So thank you. Okay, so just to make sure everyone can be heard, I'll pass the microphone around. So if you just raise your hands and I'll come running over to you. So.
Within the US system, there is something called the extension program. And it's national, it's also statewide. So this extension uses a lot of CPPR to help with health promotion. Stakeholders happens to be community based.
Yes.
But one of the issues that we have is finding healthcare access to those individuals. So they may have health need, but the local community actually don't have health access, or say providers going into the community to provide. How are you coming? Well, if that's a problem, how are you bringing providers to the local community?
Yes, we have a little different system in Sweden than in the US. But actually, I work with Nina Wallerstein in the US, and we have trying to work out how to do these models in different ways. So in Sweden, we have the primary care with us. So they are with us in the program. And they are also those coming regularly from the primary care, talking to the women and asking them what they need and so on, and having education together with them. So there will bridge over between the community and the primary care. And I think this lay health promoters are very important there. And as you, and maybe you know that lay health promoters is all over. But the big problem is where they are going to be employed. Because if they are employed by the healthcare system, then they need to follow their regulations. If they are employed in social care, they have to follow them, this organization. So what we try to do is to find a new organization that can employ them in another way. So that's, I think that's the new thing, because these people are employed, many of them in the healthcare system, I know, in the US and Canada. So there is a problem, because then you have to follow the healthcare regulation, and that's part of this. So what we try to do is to do organization, a governance organization, filling that gap. So I think that's part of the success.
One here, I'll just so I'm just
Thank you.
So my name is Harold Armenta. I come from Technological Monterrey, Mexico. First of all, thank you for your presentation. It was really inspiring. I was very curious about the tracking and evaluation process of the program itself. You mentioned something about the data that you use, but I would like to know a little more about what sort of data about social and health indicators that you use to evaluate and hopefully optimize the program. And if so, do you use any sort of like statistical model, like it's an epidemiological model? And so how do you present this data to your stakeholders especially to your participants? I will be very interested. Thank you.
As Sandra said, working.
Yeah.
So what we have do is that we use quantitative data self-reported quality of the health literacy, stress score, for example. Now, and we also have focus groups with everyone. It's quite exhausting. 300 people to follow the program so that they can also interact with us and we can change things. But of course, we have to do something else in the long run, because this is very exhausting, both for the researcher and also for the organization. Yeah. So that's our next goal, actually, to find something that will work also.
Thank you, Alice. Very helpful.
So much for your talk, especially for the previous questions on this one. We really appreciate the work that community health workers or lay health workers do. They have been very successful in the US, at least in Utah, graduating from the university, and we're trying to improve them in the university extension setting.
Oh, good.
They're implementing that and see the great value of community health workers or lay health workers during the pandemic. They were the ones that were the first line. So thank you so much for mentioning. My other question would be, or my question would be about politics.
Yeah.
You mentioned that the city will apply some of the programming, and at least in the US or in Utah, like each state has their own laws and everything that has to do a lot with healthcare and policies. So what's your recommendation to deal with those changes and to be able to still make your program successful, especially since funding is connected to that and two or three different views about what diversity and access to care looks like?
I think it's important to politicians also, not necessarily in their work, but so they know what we do. It was the mayor from the city talking in the video. So they have been a lot of meetings, and they have also been out in the community, and you have to interact with that level too. And then it will be spread as a good example. It's very important to have relationship also with that are important, so you can talk to them. So what we try to do here is to organization to show that this maybe is something that we can scale up. And then we have talked to also the state with the departments that are in charge of this kind of work. But it's so different from US. But I think it's very that you also have these dialogues all the time. I've been out talking a lot. I have a little problem talking in English because it's Swedish, and then I'm very, talking very free. So you have to talk many people having dialogues about what you do, show result, and interact with that.
Thank you. I'm John Weston from Canadian Health and Fitness Institute. Thank you, organizers and Professor Rämgård, and Professor Strange for bringing us to Sweden to our first conference here, and for the donuts at the entrance. You're talking about epistemological filter, and I think it's a mark of success in that genre when you can put one slide up that helps a listener or viewer understand who they are and what they're doing. Your slide on social impact with the Venn diagram was very interesting. And it showed that the role of the NGO was important, but one of many, and without the others, you're not really strong, but together you are. Our organization focuses on the role of physical activity. You mentioned that at different points in your presentation. I wonder if you could elaborate on the role of physical activity for health, for diabetes, and the other ills that you described, and also the role of the NGO.
Yeah.
Because sometimes we feel like we're not listened to, that we don't have a voice.
Yeah.
But you show that there's a real important role there.
First question about physical activities is very important, but it is the kind of physical activity that people want to do. If I take the yoga, for example, there was only, I think it's 20-30 started wanted to have yoga, and then they wanted to decide because they wanted to go outside, taking off. But today it's it's yoga every day. It has become very important. And also we have a yoga leader that is from the same culture. So that's one thing that is very important. Physical activities. It's also important that physical activity is not something very strange. It could be taking a walk together, part of your daily lives, part of the social interaction. I don't know if I answer your question. So it's been different interventions. Rati, can you maybe explain more later about physical activity, specific form of physical activity that she had in her PhD? That was very important for her. Which is very much about how to strengthen the physical capacity by doing the things that I already do. Taking walks. For example, there were many women that in the beginning that was afraid of walking in the. So we have walk classes and so on. So that's the first question. The second question is very important, of course, with the session we have. Today we have the Save the Children has employed the lay health promoters today because they have to be employed somewhere, but they're working in this governance organization. So it's not their structure inside their organization. It's more the goal is. So I don't think you can do this without. It's also in the city of Malmö. Malmö City has decided to give money from the city council to local governmental organization to work in the areas of Malmö. So that's also.
Just like to follow up.
and I have a perspective of architecture. And I was wondering, it's my first time here. The city is very expensive. However, physical activity is a concern for these ladies. They live in the city and that city, right? It's like working. One of the basic things that they do every day, then they have that concern of the physical activity. It links back to where we started. We saying that people in the afternoon the children will be taken away, so forth. To their friends, speak to their neighborhood. So what do you think about this thing between the building and speed?
Yes. We have a program looking at what is the kind of barriers for physical activity. So, say, as it is for them to side this neighborhood to other places. For example, in summer, we have excursions around the region, Scania, so then they were actually riding stairs because they really know, and they could also come outside.
Hi, I'm Andrea Pazziani, a Plenary Assistant Professor of Comparative Law from the Sant'Anna School of Studies of Pisa. And as a lawyer, I am curious about your experience with the law context of this program. You had to deal, of course, with the regulatory and legal framework to
Yeah.
So what was your experience? Did you experience the law more as an obstacle or as an enabler?
Say both. What that obstacle? Well, for example, we have the housing companies with us. And they were also part of some activities. But they had organization that they had to have their
Social security.
yes, security on the list with their activities. And we don't. You see? That's a problem. So there are problems, yes.
We have just should we just quickly just explain?
Yeah.
Hi. I think the physical activity intervention in my thesis was about, it was designed together with the population because they said that they wanted to be inclusive. They wanted to be something that they could use in their daily life, but they didn't need equipment, special equipments to train with. So for instance, one simple thing was the climbing up the stairs, up and down. How should your body position be? How should you get up? How should you sit down? How should you carry a packet of vegetables from the grocery store? So how should you keep your body position during this time? How could you use these instruments as what to say, equipment to train? For instance, they wanted to know, they got to know that they could fill a bottle of water and then use it as a tool to train. So there are many things that they learned practical that didn't cost them. And at the same time, something that they could do at home. The same thing that Margareta was talking about, because these people did not want to train in open. They did not want to train in gym where other men are there. So this was also a cultural barrier for them, that they couldn't train in public places. So they needed something that was for them. And this was a more inclusive program. So it had different components. So they themselves identified that, for instance, diet is part of this. If I train and if I'm not eating good food, if I'm not eating a balanced diet, then it's not about how much I train, it's about everything together. So we created this package together with them, and one of the health promoters who was then working with us was also a physical activity enthusiast. So he, together with the population, created a packet for them to work with. And the goal of this package, the physical activity package, was that it wanted to include everybody, irrespective of their possibilities and their abilities to train. For instance, there were a lot of people who couldn't sit down and get up, a lot of people with muscular dystrophy and other problems that they could not train. And at the end of the session, many of them started to sit down on the floor with their legs. Those who started on the chair started to sit down.
Very much. There's one last question.
Thank you. Session. I'm Soraya. Sure. So I would like to should this a little bit on the resources. In terms of the resources. Also, I would like to know the involvement of because all cases, all movements that the promoters is the participant in the movement. How about the men?
I start with, I always get that question. I would say that the women are the driving forces, but it are also, for example, Rati mentioned the mayhem band. But these activities are daytime, for example. So many men are they are with us in some of the activities, but there are much more women and children involved. And it's always a bit of a problem. But what we can see is that one thing that happens was that there was more where we have worked very much with what kind of food should we eat, so on. Had a lot of health circles. And that it was so the men in the families. It was the women cooking. So some of them also wanted to start activities on the weekend. So there are now activity on that have bring their children, they're also guys, to specific activities in the weekends. So they are there, but there are a few, yes.
Sorry, we didn't get around to all the hands raised, but for those who still have questions, please do come down to the front and speak to Margareta. I know she'll be very open to chatting more. Before we go to coffee, then I can ask yours to pause. Margareta, thank you very much. So we now have a coffee break for 30 minutes. And you very much as already mentioned, you have the QR code, the program, just to you're going to. The majority of the rooms, as I understand it, are up on the 5th floor. There's one which is on the 6th floor. To get to those rooms, you can either take the elevators in the A or the B section. So right now we're in the C section. We go just in that direction or that direction. Or if you're feeling like you want some exercise, then you can just walk up the stairs in Central Asia. Thank you.
After the presentation. Yeah, I was going to tell them, so I'm glad you did that. I was like, we need to tell them where they're going.
I think it's a good job.
Yeah. I don't need